Great, hello and welcome to everybody who's joined us on this NHS X Innovators event. This is our fourth Innovators event, and those who've been with us for all of the events will remember we first had our Innovator event just over a year ago, and NHS X is one last week, so we're delighted to have our first birthday, and we're delighted to welcome you all back to this event. We've got around 500 people joining us today, so we're really pleased to welcome so many people onto the call. In terms of the call, we will be recording just to make people aware, and you will be able to ask questions. Just pop those in the live chat, and we're expecting that we will answer a few of those questions, probably not all, but we will be able to respond to those questions after today. So just a little bit more about the agenda today. We're thrilled to have our speakers. You will recall that in October last year we produced our document listening to Innovators, which was a response to all of your feedback on the top 5 things that you wanted to help us with. So you identified tech standards, procurement, digital capability, communication and approach and scale as the top areas that you wanted to have help and support on. And we've worked on these areas with our colleagues from across health and social care. And in this session, we'll be looking at tech standards and digital capability. So as well as those 2 key areas that you've mentioned that you wanted to have feedback and update on our work, we'll be hearing from Tara Donnelly, Indra Joshi, who will update on the AI work that she's doing, and Matthew Gould, who will finish off with a roundup and next steps. So without any further ado, I'm going to add and move over to our first speaker and welcome Tara Donnelly. Thank you, Tara.
Thanks very much indeed, Lisa, and it's really great to be back. We had a beautiful programme in place for the full year back in January, and it was going to take us to some glorious cities, to Newcastle, London, Birmingham across 2020, but lo, it was not to pass. But instead, like the rest of the country, we're learning how to do things in different ways. And a great bonus is that very often when we publish details of these events, within a couple of hours, the places are full. The joy of being digital is we can welcome as many people as would like to join us. So it's fantastic to be able to accommodate more people. And as there are very new people to welcome, I want to say hello. My name is Tara Donnelly. I'm the Chief Digital Officer at NHSX. And I'd like to take a few moments to really reflect on some of the highlights. It's a very personal perspective, but some of the highlights from the tech response to the pandemic. And just a word or two to say, what is NHSX if you're totally new to us as an organisation? Well, we exist to accelerate the digitisation of health and care, or to put that another way, to give citizens and staff the technology that they need. We're a joint team, as Lisa says. We were established exactly 12 months ago from teams at the Department of Health and Social Care and NHS England to bring together in one place tech strategy, policy and delivery to give coherence and to speed things up. And as you've heard, it was our birthday just very recently. And looking back to that first week of our existence, we ran our very first event for Digital Health Innovators on the 4th of July 2019 at Tech UK, that we subsequently wrote up as the document that Lisa's mentioned, Listening to Innovators. And one of the things you told us is that you really value events where you get to hear firsthand about the work that we're doing, and we get a chance to listen and have feedback from you too. And you asked, would we please keep these going? And voila, hence we are here today. So technology has played a major part in the response to coronavirus right across the world, and our country is no exception. I think the tech response has been nothing short of extraordinary. We've had OpenReach vans deliver donated Facebook portals to care homes to connect shielding residents with their loved ones. A British startup enabling people hospitalised with COVID-19 to return home earlier and use an app and a pulse oximeter to let clinicians review their care as they recover. We have had internet service providers ramping up the bandwidth of clinicians reviewing patients or medical images from home, and another British startup providing video consultation functionality to GP practices. These all happened incredibly quickly, and the examples I mentioned also happened without any charge to the NHS, because these were part of those companies' response to the greatest challenge the NHS has ever faced. At NHS X, we've received over 800 offers of support, several pro bono, and we've sought to make use of as many as possible. And we've also been gifted staff from across Whitehall and from organisations as diverse as the CQC and the Royal Albert Hall, growing at our peak to 3 times our normal size, with the vast majority of those being volunteers who joined us to help. Casting our mind back to the beginning of the pandemic, very early on, it was clear that we would need to rapidly access more hardware to keep services going while NHS staff complied with lockdown and stayed at home where possible. You might remember everyone was after laptops and tablets, and there were shortages during that period that the manufacturing bases in China were closed. And when we spoke to manufacturers, they were really eager to support the NHS, but were concerned about having to let other customers down in order to prioritise frontline workers. So it was really helpful. We asked for a letter of support from the Secretary of State for Health and Social Care to provide some direction at that moment. And since then, 40,000 laptops and tablets have been provided, with around 50,000 video consultations being conducted every day now, as well as thousands more online consultations and through phone calls, keeping the NHS going despite the need to shield and socially distance. We also set up within a few weeks a national deployment support team staffed by the Academic Health Science Networks and other really generous volunteers who worked with primary care locally to achieve this change. And thanks to NHS Digital, all 7,500 GP practices are now connected through GP Connect, meaning it's possible to share critical health records and make appointments between practices. And another thing impacting people early on was access to food, and a team within NHSX worked on this, supporting vulnerable people at home, as well as securing priority food delivery for NHS and social care staff. There was also a huge push on connecting up health and social care, with over 11,000 care homes rapidly onboarded to NHS Mail, using bots to do this as quickly as possible. The rollout of Microsoft Teams has been crucial to the successful overnight shift to home working across the NHS. And you'll have seen that recently we announced a new deal with Microsoft, supported by colleagues at NHS Digital, which will save the NHS some hundreds of millions of pounds a year. We've seen a huge increase in the volumes of staff using the e-learning for healthcare resources, which James may mention in his section, including 1.57 million staff in the NHS and social care accessing the COVID-19 training package. The average rate for last month being 10,000 session launches a day. And one of the most popular advice pieces we've published at NHSX is a very simple, succinct one-pager on information governance and how it mustn't get in the way of good care. Use of services such as the original NHS app have expanded significantly, including for requesting repeat prescriptions, and medicine home delivery has increased markedly, with some of the companies in this space talking about usage having tripled since January. A video made on how to do a video consultation with your doctor has been viewed over 7 million times, helped by YouTube at our request promoting it on their homepage, was part of a campaign that Nicola's been involved in called Health at Home. The number of people accessing 111 online has increased by more than 50 times since January, with almost 3 million online assessments completed. And there have been over 25 million views of the COVID pages on nhs.uk, which has been zero rated by the telcos for the duration of the pandemic. We know that clinical communication becomes even more critical when the workforce is impacted, and so we're running a national procurement to help get tools like this into the hands of more clinicians, and another to help scale remote monitoring platforms that have a role during the pandemic and beyond, as supporting people at home becomes our future focus. We want to support a vibrant ecosystem in digital health across the NHS and social care, as well as work with the 7 regions across the NHS in England to accelerate scale of remote care tools and the connecting up of care homes to health services. But looking back over the past few months, perhaps most importantly of all, we've seen a mind shift change in the public and the NHS alike, with digital solutions being embraced like never before in health and care. There are many examples of more being progressed in digital health in weeks than previously would have taken years. And how do we keep this going? This new appetite for accelerating digital solutions, making decisions promptly and implementing. A change in the perception of risk that has really dogged the NHS in the past. Right now, it feels for the first time more risky to fail to try things than to try things that might on occasion fail. And also a real commitment to both collaboration and scale, with nobody saying they won't use something because it's not invented here, and many saying that they want to scale what works for others. One of the barriers to scale that I have personally found most frustrating in the past is when a clinical or an operational team has found an evidence digital solution that meets the needs of their patients, and yet the cogs of decision making turn so slowly that there's often a real aversion to risk and a simple fear of trying things that are new, that the idea never sees the light of day. And that's one of the things that's really changed recently. We have seen over recent weeks decisions have been made refreshingly rapidly. People are trying digital solutions for the first time, and in many, many cases they are realising that the fear that they held was unfounded. It would be amazing to keep this mindset once the outbreak is over. So the next stage of work is to embed this, build on it further to truly make it part of mainstream medicine. And we're also mindful that coronavirus may well be here to stay, and that digital solutions that can assist in any subsequent wave should be prioritised and scaled. So we're as ready as possible to keep services going now and in the future. Thank you.
Thank you so much. That's been a fantastic summary of some of the wonderful work that's happened over the last 3 to 4 months, where technology has really come into its own, and the priorities at NHSX. So I'm going to move straight to James Freed, who's our next presenter. So just to introduce my colleague James. James is the Chief Information Officer at Health Education England, and he is going to talk about innovation, culture and digital readiness, and we'll talk for about 10 to 15 minutes to colleagues, and we will pause for some questions after that.
Thank you. Thank you very much, Lisa. So yes, I'm the Chief Information Officer in Health Education England, and thank you ever so much, Tara, for mentioning the e-learning for healthcare success. It's been a real eye-opener, and COVID has, I think, changed people's perception of e-learning, and it's translated through into use. But that's not the reason I'm talking to you today. So one of the reasons why you are here is to hear about capability. As well as being the CIO in HEE, I am the Deputy SRO for a programme called the Digital Readiness Programme. It's funded by NHSX, supported by Health Education England, and incorporates all the work that we're doing as part of the NHSX digital transformation portfolio on supporting staff development across the whole of health and social care. Could I have the next slide, please? Thank you. I thought I'd start with a little bit of a sort of personal take on innovation in the NHS, taking into account Tara's observation of some digital projects moving at tremendous pace, pace we have never seen before. There are still plenty that follow the age-old model in the NHS of there being large numbers of innovators and large amounts of innovation, and then suddenly, as soon as it hits the NHS, the brakes are put on. I remember at one public presentation, one of the people who asked me a question from the audience described it as glacial. I said, why is it so glacial, the uptake of technology into the NHS? This slide is really just observing that fact. There are so many innovations out there, but adoption is relatively small. Adoptions that make a real impact are even fewer, and then dissemination, where we see that true rollout across different sites, and the increase of any particular in any individual product across the NHS is even slower still. There's another way of looking at that. Next slide, please. And that's around rate of change over time. Now, this red curve, it's analogous to the numbers of innovators and innovations in the world, really, and it's a well evidenced and very measurable phenomenon. Many of you will have heard of Moore's law. That's the recognized and observed doubling of components on computer chips every 2 years. We see similar exponential rises in the data and knowledge industry. Just look at peer-reviewed journal capacity, or indeed numbers of petabytes that are available via the internet. This exponential change is synonymous with opportunity. The opportunity that data, information, knowledge and technology gives us as a species is exponentially increasing. The issue, however, comes with this blue curve, the curve that's analogous to uptake and adoption, and that's around human adaptability. The fact that we as a species simply are incapable of making use of that vast amount of innovation, that vast amount of opportunity that is now available to us. We're just not able to put it all together in the best way. We're not able to see the wood for the trees. We're not able to spot where those innovations can be best used. And that gap between our ability, our human adaptability, and this technology curve is increasing over time. Now, technology itself and cultural changes do help us to adapt better, which is why that blue curve is increasing, but it's not increasing exponentially. And if I could have the next slide, please. Really, that's the core synopsis of the digital readiness program. Our aim is to try and bend that human adaptability curve up, that capability curve up. And we want to do that in 2 ways. Firstly, we want to help everyone learn faster. And secondly, we want to help every organization govern smarter. Next slide, please. So how do we do that? So this is my program on a page slide. We've got 6 broad work streams, and actually, if I could divide up first, before talking about the work streams, I'll divide up in your mind's eye for a second the entire workforce in health and social care into 3 broad areas. So we've got 3 million people in health and social care, about 1.4 million in the NHS, about 1.6 million in social care, and we see we can at least conceptually divide those 3 million people into 3 groups. The first is what we call our senior leadership group. These are the individuals, usually our executives and non-executives in the social care world, our owners, and in larger social care providers, our boards. They're the senior leaders who set culture, direction, approach and vision for our organizations. And we know from the evidence that we've accrued that there is a key difference in between how we currently run health and social care organizations and how we should run health and social care organizations if we want to be truly adaptable and truly flexible, supporting innovation at pace and scale, but also safely, crucially. Let's not forget that we are the most dangerous industry in the world. And when we get things wrong, people die. In fact, actually, when we get things right, sometimes people die. It's a dangerous industry to work in. And so necessarily that makes us risk averse, and that contributes to this culture which does not support innovation. So we've got a work stream that's specifically around addressing that. It's work stream 1 here, supporting our senior leaders. We've been investing in a number of products, and I'll be talking about the work that we've been doing with NHS providers shortly around how we support senior leaders in the NHS specifically to be creating those cultures that are more flexible and more adaptable to change. The second group in our imaginary division of workforce is our digital professionals. We've got somewhere between 41 and 53,000 informaticians, so people who work with data, information, knowledge and technology as part of their day job in the NHS, as the main part of the day job in the NHS. We don't know how many of informaticians we've got in social care. Workstream 2 is around supporting those digital experts to be professional. So it's been investing in professional bodies like the Faculty of Clinical Informatics, creating a brand new profession really of those clinicians who want to be digital clinicians and work in leading products and services in the digital age. We've got a second umbrella body called the Federation of Informatics Professionals that we've been investing in as well to help bring a certain amount of order and support to the professional environment. And those 2 bodies together are helping us identify what it means to be good as a digital professional in health and social care. It's setting a bar for accreditation so that we all know what that expectation is, and it's supporting the sharing of knowledge and expertise through things like networking. The third programme and the fourth programme also support that same group of people, the 41 to 53,000 digital experts. The third one is about building our future digital workforce. So we recognise that we have got 41 to 53,000 people now, but how many are we going to need in future, and of what flavour? How many cybersecurity experts versus IT help desk staff versus software developers versus knowledge managers? And this third programme, the building our future digital workforce, is looking at some of the predictions from industry, predictions that say health and care as an industry is going to see the greatest increase in need for digital expertise by 2030, about a 75% increase, and work to produce models dependent on various scenarios. We're also very practically looking at the routes into our workforce. So we've been supporting the rollout of a model that came from the HIN, the Health and Innovation Network, the Southwest Academic Health Science Network, to identify, screen and support graduates into NHS digital data and technology roles. We're also working with Blenheim Chalcott and a consortia of other companies in supporting school leavers with the same agenda. Our fourth programme is around establishing the NHS Digital Academy. It has been established for the last 3 years as a postgraduate diploma in digital healthcare leadership for 100 chief information officers and chief clinical information officers in health and care. One of the biggest issues we have in breaking that glacial transition of innovations into practice has been the senior leadership in digital agenda. So how do we support chief information officers to understand and create an environment, a strategy that enables rapid and flexible adoption of those sorts of innovative and bottom-up changes? The Digital Academy itself is going to be expanded, so we support not just 100 people a year, but hopefully one day all 53,000 of our informaticians to develop digital expertise. The fifth programme is around digital literacy of the wider workforce. So this is the third broad area of the workforce, and that is everyone else. How do we identify what digital literacy means for a 21st century workforce, and how do we support it? So that programme has been creating a self-assessment tool and signposting, working with organisations like the Institute of Coding and the academic sector to try and identify the best way to deliver bite-sized learning to individuals from clinical or non-clinical backgrounds right across the health and social care workforce. And then finally, we've got a sixth programme around supporting our social care workforce, recognising that social care is an entirely different industry to healthcare. There are different routes to influence, there are different mechanisms, there's even a different language. And the supporting our social care workforce work stream is there to ensure that the products and services developed by the other 5 work streams have a social care aspect that enable uptake. Next slide, please. So the NHS Digital Academy, this is cohort 1. I'm in there somewhere, although I can't quite see myself. As I said, there's a consultation on at the moment to think about exactly how that expansion is going. At the moment, we're thinking specialist academies to support particular domains. So, for instance, we're keen to work with data practitioners and the Association of Professional Healthcare Analysts to develop a data specialist academy. We're also looking at a foundational certificate and specific qualifications for chief medical officers, chief nursing officers, dovetailing with some work, well, the work that we are doing around leadership. Next slide. And that's what I'm talking about here. So the work that we've been doing with NHS providers to launch a really interesting and innovative programme of board level development aimed at senior leaders in the NHS. The core to this is the concept of digital in a day development sessions. So where boards can learn as a team to develop the behaviours and the culture that we need to see as boards as a whole and board members as individuals in truly flexible organisations. It's supported by a number of how-to guides, video clips, a knowledge hub, go see visits, and also seminars that support the development of learning within specific role delineation. So, for instance, non-executive directors or chief executives or chief finance officers. We went live with the Digital Boards programme last week, at the beginning of last week, and we will be conducting the first board development sessions this quarter. Next slide, please. And so that's a whistle-stop tour. I've included 3 links, which I understand will be circulated after this event. So if you want more general information about the digital readiness programme, there's that link at the top, the Digital Academy consultations in the middle, and then at the bottom there's the link to the NHS Providers Digital Boards Resource Hub. And I'd be really interested to hear any feedback that you have, and my contact details are underneath. Thank you very much.
Right, and thank you very much, James. So we do have a little bit of time for questions, and thank you for all posting those questions. So I've just picked a few out of the most liked questions, and of course we will answer all of these on the tomorrow, but just to pick out a few, there's quite a few comments around how we can maintain momentum and how important it is to do that, and comments on the role of health charities in supporting digital readiness. So I will just go to Tara, if that's okay, Tara, for those, and then I'll loop back to James.
Sure. In terms of maintaining momentum, well, we'd love your ideas as well. We think there's something about really sharing what some of the benefits have been, having case studies, having descriptions from peers about the change are really powerful. Some of the most interesting things I've seen are where people have said that they actually really were quite skeptical, for example, about the value of video consultations, but they have realised how enormously helpful they can be for a whole tranche of conditions, and that also working in a different way is giving people more time for the very essential face-to-face care that's needed for certain patients. So I think there's something that everybody can do about messaging expectation. Patient pull is often it's stronger, I think, than people in the NHS expect. So I think it's a job of work for all of us to think about how can we kind of really lock in the changes that have happened and add to them. And I think we've also got to recognise that it's been far from an ideal scenario. There's been a kind of necessity being the mother of invention period, and we wouldn't kind of, throw technology at people in normal times. So that as things get a bit calmer, we really think about the ways in which we make this a more attractive way to both work and to link with the NHS. So grateful for supporters from certainly from charities, but across the community, really, about how can we make this part of business as usual.
Thank you, Tara, and over to James. And I'll just throw in another question, James, for you that came up, was how we can continue to attract the best talent in the NHS, best technical talent.
Thanks very much. So the first question was around the role of health charities. I guess the short answer is I'm not sure, but I'd be really interested to hear what you've got in mind. We do already collaborate with a number of charities, organisations such as Future.now, and those that have got a particular interest in the support for capability development and workforce development. But if you've got any specific thinking in mind, one of the purposes of doing a session like this, from my perspective, is it gives the work that we're doing greater visibility and also enables you to contribute any ideas that you have. We've long had a philosophy in our programme around joint working and collaboration, and I'd be really keen to hear any ideas that you've got. The second question, Lisa. Sorry, could you just remind me?
Yes. So the second question was how we can attract the best talent and maintain the best talent in the NHS and social care.
Yeah, really good question. We've just been doing some work on workforce planning, actually, for the digital data and technology communities in the NHS. There is I guess a sort of a received wisdom that the NHS doesn't pay as much as industry, and it turns out that is true, but not as much as we all thought it was. The NHS has got, well, health and social care has got the best statement for why you want to work for the NHS better than any other industry, as far as I'm concerned. You know, the NHS saves lives. What else could you ask to do that's better than that? And what we are seeing, though, is a trend change that's generational, actually. So younger entrants to our workforce care much more for those sorts of altruistic reasons for joining a job than maybe some of the people more my age. But we are seeing that things like salary doesn't account for that sort of decision making as much as it used to. So I'm anticipating that if we maximise the visibility of the reasons why you may want to come and work for health and care, and we help create teams within organisations that are fun to work for, that get to play with all the nice new tools and gadgets, and that there is a clear line of sight between the work we do and the lives we save, I think that we stand a good chance of meeting that 75% deficit.
Thank you. And just a couple of questions I think we've got time for before we move on to the next speakers. So we've had a specific question about NHS login, and people are keen to hear if the NHS login offer and that programme of work is still continuing, which I'll move to Tara. And then I will loop back to James again with a further question on how he measures success. What are the benchmarks of measuring success of your programmes? So just over to Tara first for NHS
login is carrying on. They've seen a huge number of new registrations, as you can imagine, during the COVID period. So yeah, no plans to discontinue NHS login. Doing a great job.
Okay, so over to me for that question around success.
It is.
Right, I promise I will answer, but first I'll give you my my excuse. So the measurement of educational programs has long been difficult. So measurement of success in educational programs, one looks for proxies. Having said that, so things like digital literacy, so the creation of a self-assessment tool enables us to measure a sort of an objective level of digital literacy for an individual, an organisation, or indeed the entirety of the NHS. And we are at the moment trialling that to see whether we can do something not dissimilar to, if you've heard about this, the patient activation measures. So they measure different things, but patient activation measures gives a numerical figure on how active an individual patient is in managing their own care, understanding and seeking the correct advice and support, and tackling issues themselves about a long-term condition that they have. We've been following a similar educational model in the digital literacy space, so measuring confidence, motivation and expertise in digital literacy against our capability framework, which incidentally is published. Have a look on the Health Education England website, and that will help give us an objective measure about how digital literacy improves over time. In terms of other programs, many of our measures at the moment are proxies, so things like how many registrants for the Faculty of Clinical Informatics or Federation of Informatics Professionals, or how many boards have undertaken a board development session. But we're looking more and more for outcomes measures in any of these sorts of things. So for instance, the Digital Academy, we conducted an evaluation to look at what the outcome was in terms of different decisions made by the, admittedly self-reported different decisions made by the individuals who went on the course after the course, and how they attributed that learning to specific decisions and what those outcomes were in terms of saved money or reduced time of adoption. I suspect we'll be able to do something similar for the board level development work, but we've not finalised our evaluation of that yet. We are really keen, however, to look for outcomes-based measures.
Wonderful, thank you very much. So we're going to now move on to our next speaker, Nina Wilson. Dr. Nina Wilson is a GP and has been supporting us on the tech standards. Colleagues who came to the last Innovators event will have heard Nina and her colleague Rod Joyce talk. And over to you, Nina. Delighted to hear back from the consultation on tech standards.
Hi, Lisa, and hello everyone, and thank you. Yep, just here to update you on where we've got to with the digital health technology standard work. Quick reminder, this work is around streamlining the NHS assurance process for digital health technologies so that the benefits can be brought to patients as quickly and efficiently as possible. And part of that streamlining is simplifying it where possible. Another part of it may be speeding it up, and another part of it is making it really transparent so that everybody knows what we're looking for and what we're trying to achieve with this. We have a programme of work on this, and part of it is setting out the standard and making that transparent. And then obviously the work that follows on from that is how we assess against that standard and how we link that up with procurement and so on. And those of you that attended the last event will remember that at the last event we launched the digital, what we called then the Digital Health Tech Standard for Consultation. And that was the document that set out the categories in which innovators would be expected to submit evidence to provide assurance that their product met the appropriate standards of safety and quality and data protection and so on for use within the NHS. And that document was put out for consultation just before the COVID lockdown. The good news is that through our engagement partners MedCity, we were able to continue with that consultation during lockdown, even though many of us were pulled onto other projects. So it was great. We managed to engage with lots of you, got lots and lots of valuable feedback, and we were able not to lose time, if you like, with this project, because although we had to do a lot of the consultation remotely, we were able to continue. And I'm really grateful for all the feedback that we've had on that original document. We had 1,573 comments, which I've been going through every single one of them. And what we're doing with that is we're incorporating all of that feedback into the next draft of the document, which is currently being drafted and is with.
I think we've lost Nina for a second there. So while she comes back, we're just going to take the opportunity to ask a few more questions. So there's quite a few questions on people wanting to link with NHSX and how we can best work together. And of course, we did get a phenomenal amount of offers during the COVID period, which we were delighted to receive. So I'm going to loop over to Tara for a second on the how to get involved and engage with NHSX, and then I've got a few more comments and tips about how we can get people engaged.
So I'm not sure, do we put up the email address at the end about the NHSX?
We certainly can, yes. So
we can do that. Put the contact email address if you'd like to get in touch, and someone will get back to you.
Great, okay. So just to add to Tara's comments, we've got a really live programme of innovation surgery. So if you do want to come and have a chat to us and either look at where you want to get more information about what's happening within the NHS, or more information about what is happening with your a programme of work or connections to people in health and social care, do contact us on that email address, and we can get you into our innovation surgeries, and we can support colleagues who want to receive more information, or colleagues who want to discuss their programme of work in particular. We did have another question about virtual consultations in outpatients, so I'll just take this opportunity to answer that question. So the outpatient question, Tara did say a little bit about how successful running virtual consultations were, and of course they are for a cohort of staff. We've been doing a large amount of work on looking at a range of options, from people having telephone calls, people having remote consultations where that's appropriate in primary and in secondary care, and where we can support patients in their own home, and make sure that we use some of the fantastic devices and kit that people have been developing in their own homes, and use that to link to a digital platform and support shielded patients or patients who have been discharged from hospital on the COVID pathway. So we've really extended our work in this area, and we're expecting to see many more models of new devices and new digital platforms. And many colleagues will have seen and applied for the new procurement framework that we put out about a month ago, to capture all of these areas, that the outpatient tools, remote monitoring tools, and tools that measure pulse oximetry, for instance, and measure vital signs in people's homes. So those really important areas. So I think we've got Nina back now, so I'm going to conclude those questions and welcome Nina back.
Thank you. Sorry about that.
See you back.
I am back. So I hear you've been having some questions in the meantime, which is great. Yeah, so I was just saying that we had lots and lots of really valuable feedback. And as you can imagine, there were some common themes within that. There was consensus in the support for this document and the aims of the project to streamline this and really make it clear to SMEs and innovators what it is we're looking for, and to support them with that. And as well as some really useful pointers and challenges about what we were doing. So there were some quite clear calls for clarity in the document, and also for proportionality in any assessment process, so that it could be proportional to the complexity and the risk of the product, and also to the life cycle of the product in terms of its development. And that was particularly relevant to evaluation. So as I say, I've been taking all of those comments on board and reworking that into a second draft. It looks slightly different now, and what you will see when we publish it is it's been reworked into effectively a supplier's guide to what it is that we're looking for in the NHS, to really kind of try and open that up and make that clear and accessible to suppliers who may or may not have a healthcare background or come from this industry. And there will also be notes for commissioners as well, because we had some clear calls from commissioners for help and support in being able to work out what good looks like when it comes to a digital health technology. So that's well underway now, and very shortly we'll be launching the next part of this whole process, which is to review how we assess products. And we want to again work with you very closely to get all of your input on how we can best do that, how we can do that most efficiently and effectively, so we don't duplicate work that you're already doing. You know, if you're having to CE mark your product, for example, what can we reuse, and what can we do to minimise any burden of this for innovators. So that's the next part, and look out for that. Really, that's kind of our next phase now that we're all fully focused on this, now that COVID is over. We'll be also creating means of supporting people to understand what they need to do, and we're working with the AAC on this. We're redeveloping the portal, by which what used to be the DAC portal, but we'll be redeveloping that again to try and capture as many of the things that you've asked for in this consultation as possible. We're also making sure that this fits in with the work that we're doing on artificial intelligence and validation of artificial intelligence, so that we can get more AI in the NHS, so that all of that links up, and Indra will be talking more about that later. So I think that is it for me in terms of the update, and if there are any questions, then I'd be very happy to take them.
Great, thank you, Nina. So I think we might just go to Indra next, and then take questions for yourself and Indra at the same time. I see there's a few questions there in the chat which we will come back to. So I see we have our colleague Indra Joshi on the line. Welcome, Indra. Indra's the Director of AI for NHS X, and has been a regular presenter at these events. So we're moving over to Indra.
Brilliant, thanks Nina, Lisa, sorry, and thank you Nina as well. Can we switch slides please? So I thought what would be helpful in this session, and conscious of time as well, is just to give a brief overview of not what the lab will be. I think we spoke about that in previous sessions, but a brief update on what we've been doing over the last 3 or 4 months. And bearing in mind, as colleagues have mentioned before, you know, we have gone through COVID. A lot of staff have been deployed in different programs, myself included. I was deployed on a different program. And so I'm incredibly proud of what the team have done, despite adversity in setting up some of the work for the AI lab. So if we could skip to the next slide, please. So the first thing we did is, as some of you may recall, very early on during the response, we had an incredible number of really helpful offers. Industry, SMEs, lots of people came up to both us in the centre, but also out into communities and said, look, we've got products, we want to help you, we want to help the country in its response to the pandemic. And a lot of people said to us, we really need a bit of help, actually. If we could just skip to the next slide whilst I'm speaking, that'd be great. Can you give us a bit of guidance? And so what we quickly pulled together was essentially a checklist for people to go through when they were either being approached by companies or wanted or had found a partner that they wanted to work with, not necessarily directly related to the pandemic, but with AI. And so if we could skip to the next slide, what we did was on our website, on the NHSX website, you'll see, if we could skip to the next slide, please, we published a buyer's guide for health and care. The one we've got at the moment is what we call a version 0.1. So we published that probably about April, May time. It was essentially a checklist of 10 criteria just to have a look through whilst you're trying to procure something, understand the different frameworks that are there, what implementation considerations you need to do, and just some of the kind of basics around what is the terminology we're using. That was quite well received. What we did over the period of sort of April, March, oh my goodness, I'm going backwards in time, April, May, June and July, is go back out to stakeholders. Some of you too may have responded on the call, to say, could you give some feedback on this? And we've now had a wide range of stakeholders' feedback on that initial buyer's guide, and we're hoping to publish a much more updated version with a lot more in depth behind that shortly over the next coming months. And we're quite conscious that whilst this is for AI, as Nina has mentioned, we've also got to make sure we've got the basics right. So we're wanting to publish the updated guidance that Nina's mentioned as well, so it aligns. And some of you will also be aware that there's changes happening with the medical devices regulation that has been postponed to next year. But again, some of the guidance that MHRA put out over the last few months on medical devices, we've included on here, and it's also currently included on our NHSX website. So this was a guide to help people when they were buying products that utilise AI technologies. If we could skip over to the next 2 slides, please. The second thing we had, and the next one. The second thing the lab has done over the last 4 months is, as most of you will be aware, COVID is a respiratory condition. It affects predominantly the respiratory organs. And one of the things we've always been battling with the AI lab and across the spectrum is we have a lot of companies who come to us with a product. But one of the key aspects, especially for national deployment, for example, with PHE and screening, is we need a way of both evaluating and validating those. And so during the COVID, predominantly the pandemic, but this is continuing, a lot of the information is on the NHSX website, and it will take you to a separate site as well, where you can see which trusts are donating data, how to access that data. And if any colleagues and listeners on the call are interested in that, please do take a look at that website. And there is an email address there that you can contact for more information. But the idea behind the NCCID, so the National COVID Chest Imaging Database, is to collect chest images, be they X-rays, MRIs or otherwise, to understand how we can better understand this spread of disease. So this essentially is a big research program, and we did go with HRA and get all the right approvals. We did it quite at pace, so it was a brilliant collaborative effort across multiple different partners. But again, this was a very short project that we set up. We've shown that it's actually doing some very valuable work, and we're quite keen on progressing this as we understand, as Tara mentioned earlier, that COVID may well be here for a while. If we could skip over, next slide, please. So here is just a bit more detail of the NCCID programme. If we could skip over as well, please. And then a lot of different people asked us around regulation. So I mentioned previously, this can be a slightly tricky point. Products are coming out, they're doing some really good stuff, And one of the key aspects of the AI lab was that we would work with regulators collaboratively to actually push forward some of the sticking points that we have in regulation. So if we could skip over the next slide, please. We spoke with the key regulators, HRA, MHRA. I won't say the acronyms, I'll say what they stand for in case colleagues on the phone are not so aware of what they all do. So HRA, Health Research Authority, MHRA, Medicines and Health Research Authority, NICE, National Institute of Clinical Excellence, and CQC, the Quality Care Commission, to say how do we actually work together to push forward some of the sticking points in both digital health technology evaluation, but also in AI. And so the key ones highlighted is a multi-agency advice service. Nina mentioned, and we're working very closely with the AAC, who are also looking at creating a much more connected pathway for innovators. This will link into that. And the idea is it is, I don't want to say the word one-stop shop, but a clear place where guidance, information on both regulation and evaluation of AI technologies can be found. We're very conscious as well as we move forward from products that need regulatory, both ethical approval and then from a medical device perspective, that kind of handover process from HRA to MHRA. They've both joined forces to say, well, how do we push this forward faster? The handover process, some of this is just a technical back end, but again, it's to help make the market access these services better. The rest are around creating a safer environment. So we all are maybe familiar with the yellow card system. The yellow card system has been there for a number of years. It's attached, clinicians and colleagues will know on the call, we have something called a BNF, a British National Formulary. At the back, there are essentially yellow cards like this. They are yellow and they are a card. And they highlight when something goes wrong. Now, MHRA has been working to digitise this, and we're helping them fund a programme so that they can understand how to do that for more machine learning products as well. MHRA have already announced the synthetic data work they're doing that has proven to be quite useful. So we're helping them continue that programme. And then what I mentioned earlier, the verification and the development and deployment platform. Again, we know that these are things that innovators and the market have asked us to help them with. So we're working with colleagues to try and build some of these and also work with partners if we need to go out and procure them. And we will be in touch later during the year as we go out to market for some of these products. I think that is the last of my slides. If we could just skip to the end. Oh, yeah, no, not quite the last of my slides. The AI in health and care. So earlier in the year, we announced 140 million award for products in AI in health and care. If we could just skip to the next slide. We had a wonderful response to that. As you can see, we had about 530 applications which were received. And of those, so we split it up into 4 phases. Phases 1 to 3 were the much more earlier stages, either an idea and a conception of an idea, or a product that was not quite market ready, but almost to market ready. And then phase 4 were those that were market ready, had authorization, and wanted to have a much wider system-wide adoption. So these are all going now through the final, I can never say these words, due diligence process. And we're hoping to announce both the people who go through that later in the summer, early September. And we're also looking at creating a second round for applications in the autumn. I just wanted to highlight again with this, we had hoped, and this is us just trying to be a bit honest, to move faster with this, but no one could have foreseen COVID. And so again, quite a lot of the staff who were working on this had to be moved across to other programs. So if there are innovators on the call who are a little bit frustrated with the timelines on this one in particular, my apologies that it has taken a while. But again, as I say, we've had to work with quite a skeletal staff in this, and now we're hoping to bring quite a few of them back and ramp up the programme. Thank you, Lisa.
Thank you, Indra. So quite a lot of questions, so I'm going to skip straight to questions. So a few for yourself, Indra, and then I'm going to link back to Nina. So the first one was the importance of analytics and how we can improve analytics as a whole. So I just wanted to ask you that one, because I know you've been doing some work on that during COVID that I thought you may wish to share. And then one that says, are NHSX looking to validate AI claims? I think people are quite concerned about emerging AI that may not have the evidence base that we would wish. And the final question on AI is it possible to have conversations around the NCCID for other imagery, other modality of images? So if we take those three first, and then I'll move over to Nina.
For sure. So just to answer the last one, absolutely, we're very interested. There are some regulatory processes we need to go through. But if you do look, I think it's the AI Lab email on the NHSX website. If you do drop it an email, John, we will certainly get in touch with you on that one. The one on validating AI claims, we know this is I don't want to say an issue, but this is a lot of feedback we get from both key stakeholders, but national bodies as well, saying, well, people say they do something, but how do we know what that thing they're saying it will do, i.e. the model that they have produced will do what it has done? Like all things, it's quite difficult to try and take the whole spectrum at once, which is why we've taken a focus on imaging. And particularly we're looking at chest imaging for one, but also we're looking with PHE around breast screening mammograms too, to make sure that we get those right. This is a collaborative process, so we're working with lots of different partners to see how we get this right. We're not trying to claim to fix all problems straight away, but we will work openly to say this is how we're trying to do it. And the team right now are pulling together some papers around this. And once we're in a space to publish sort of what we found and our next steps, we will certainly do that. And I'll just briefly mention on the analytics, this is a really, really good point. I'm trying to scroll through the questions to try and find the analytics question whilst talking about it at the same time. But if I just give a bit of an overview, during the COVID process, it was really clear that the analytics community they're it's an immense community. And NHS England set up something on NHS Futures. Many of you may already be aware of it, a collaborative platform. I think right now it's got something between 6,000 to 8,000 members on it who do regular webinars to say, well, look, how do we better empower the analytics community, both to do analysis versus just data input, and then to do the analysis back, both for localities, regions, and the centre. So I know a lot of work is going in that. There's also work to say, how do we make this a profession that people want to go into as well? We at NHSX have a data analytics team who are working very closely with the NHS England analytics team to say, how do we create a professional response to this and a bit more of a training programme. James is also on the call, so again, they've been reaching out to HEE to do that. So it's a very dynamic space. I think the recent pandemic has really given us all a lot of food for thought. And there's a lot of good work that's been done despite the pressures. And we're really excited to continue this work. Thanks, Lisa.
Right. And then just a final question that's snuck in there on, can companies access the data on NCCID to work and research with? Are we at a stage where we can do that yet?
Yes, absolutely. So again, I'm just going to redirect you to the NHSX website. If you put in NCCID, there's a link at the bottom which takes you to how you can access the data. But also, if you happen to be a trust, I don't know if there are trusts on this call, and you have data you would like to donate, there is a process there and the arrangements and the processes you need to go through.
Wonderful. And then just a question for Nina. The question was, when will the next draft of the tech standards come out? Are you able to say a little bit more about that, Nina?
Well, as I say, it's being internally reviewed at the moment, so we're looking to publish ASAP. But I think we would plan to have this published by the autumn, so by the end of September.
Great, thank you very much. Okay, so great, thank you for all your questions. I'm just going to check if we're ready to go to Matthew now, to our next speaker. So I'd like to introduce Matthew Gould, who's the Chief Exec of NHS X. and we're delighted to have you join us, Matthew.
Thank you, and thank you to all the previous speakers. And it's really good to hear everything that everyone is working on so positively. Let's go back a few months, where at the start of the year we were feeling quite pleased with ourselves. We had our budgets all lined up ready to go for the start of the new financial year. We had our programs ready to go. We had a series of activities that we were all ready to press go on, and then events happened, and we ended up focusing, I mean, really, as everyone, on how to deal with the pandemic and dealing with the disruption and the requirements of the moment. One of the positives that has come out of it, which I know has been much talked about, has been the extraordinary steps taken on digital transformation across the system at a speed that people really didn't think was going to be possible beforehand, to a scale that a lot of people thought we'd never reach. And to run through a few examples, I mean, first of all, the use of data, both nationally and locally across the system, the way that data, we've been able to get data to flow safely, but in a way which can help both the people managing the NHS's response and individual clinicians for individual patients, the way we've been able to get the data to flow better, more effectively, I think has been really helpful. The approach to information governance, I think, is extremely telling. One of the things that I'm proudest of about the NHSX response to the crisis was the one page of guidance we put out right at the start, which was incredibly straightforward, couched in very simple, empowering terms, endorsed by the Information Commissioner and the National Data Guardian, that basically just said, if you do the right thing, if you're treating patients in good faith and you're sensible, then it'll be fine, and get on with it. And right the way across the system, I've heard echoes of that and the impact that it's had. Yesterday, for example, I was down in Devon, and they were saying to me that a mental health trust in Exeter had heard that guidance and it had liberated them. And there's something around what happened then that we need to capture. There were other things that we did. I mean, at one stage, it became very clear that the channel shift that had happened at such pace across the system had resulted in a huge shortage of laptops. So we've sourced 40,000 and shipped them into the system at breakneck speed. And then there was the channel shift itself, the move to remote consultations, both in primary and secondary care, which happened unbelievably fast and remarkably smoothly. Underpinning all of this was a sort of can-do attitude, which showed actually what you can do with a bit of help from some of the emergency regulations and the rules around a public health emergency. But really what drove all of this was a very strong sense of shared purpose and a sense of urgency and a knowledge that this was a moment just for getting on with it. And the single best thing I think we can do is bottle that and find a way to preserve it and make clear to the system, please carry on doing it, carry on trying stuff and taking the steps that you've taken safely and sensibly and so forth, but let's not go back to where we were. Some of what now the next stage will involve will be entrenching and really sort of locking in the progress that we've made. For example, on the shift to digital channels for consultations. Some areas I think we need to take the progress that we've made and work out what the next chapter looks like. For example, around how we share, what the appropriate way to carry on sharing data is that keeps the profession and the public with us, but really builds on the progress that we've made, and how we put out guidance on information governance, which for peacetime as well as for the pandemic, which are as simple, empowering, easy to understand, easy to navigate as the guidance we put out at the start of the pandemic. And then there's a range of areas where I think we need to build on what we've done, where we've only really just started. So one of the really exciting things for me isn't channel shift, it's transforming the way that we do consultations, reimagining clinical pathways so that we use digital tools like remote monitoring, for example, to be able to offer better and different care to people who won't have to go into face-to-face appointments or even appointments online or on the phone, because we have other ways of connecting them, triaging them, looking after them and making sure that they stay and become well. So there is I think real progress over the last few months, extraordinary progress in certain respects, a very exciting agenda for the next few months. And I wanted just to say a couple of minutes about where I want NHS X's focus to be. There is a body of work which we're calling Joining Up Care, which I think is really important and urgent, particularly given the possibility of a second wave, the fact that we're likely come the winter to be dealing with a difficult and stressed situation, and with everything that we've learned around the need to break down barriers in health, between health and care and between different care settings. I want the focus of NHSX's work to be on this joining up care agenda, which means finding ways to get data to flow safely between different care settings. So building out the network of shared care records across the country. I want us to build on the remote monitoring work that's happened as part of the NHS at Home initiative. I want us to invest in trying to drive change in the digitisation in the social care sector, in care homes and among care providers, because we've learned over the last few months how important that is. And all of that needs to be underpinned by, I think, a series of fundamental building blocks, all of which I've talked about before, all of which are familiar, but the importance of which I think has been reinforced by the last few months. We've said for a while that we want to put out guidance on what we've called what good looks like. So giving guidance to systems and providers across the NHS and care around what it means to be good at digital and digital transformation, because at the moment that guidance is striking by its absence. I think we need clarity around who pays for what, which sounds really straightforward, but I worry that we've accidentally at times sent out the wrong signals around, if you just wait for money from the centre, it'll save you from having to invest if you're a trust or a system or whatever. And I think we need to get clarity on that. I've mentioned IG. I think there's a burning need for really simple, straightforward, easy to navigate guidance. And all of this needs to be underpinned by some core interoperability standards, which speaks to some of the earlier discussions you've had. All of this is a massive opportunity for the NHS, for social care, and I think if we can get it right, for our health tech sector and everyone on the call, because the improvements that your innovation can bring the NHS and care, the increased productivity, the improved experience for citizens, the improved experience for clinicians and staff, I think are never more necessary than they are now. In all of this, we're going to have to be really careful and really mindful of the risk that digital technology, though it will be brilliant for most, might exacerbate inequalities for some. So I think there will always be, and again, the last few months has reinforced this, a part of what we do, which is about about helping those who aren't online, who are digitally excluded, to make sure that we don't accidentally exacerbate inequalities by the progress that we're making. But overall, I think it's been for everyone, for the country, and particularly for the NHS, an incredibly tough few months. But the steps forward that it has created, and that everyone on the call has been part of, in terms of the digital transformation, is definitely one of the silver linings, and we are determined over the next few months to build on it.
Great, thank you very much, Matthew. Well, there's quite a number of questions that have come in, so I'm just going to move straight to the questions. So the first one is around how we can get the care sector and the health sector to work more closely together. And I know that's some of the work that you referenced in the future work for NHSX. And I'll just quickly mention that the second couple, we have a question around, you mentioned you were about to press the button on some programmes of work. What were the work programmes you were about to press the button on before COVID? And then the final one was around how we can get better about sharing success stories. I wondered if you had a view on that, and I think I might after you've spoken, I might loop back to Tara on that one as well.
Yeah, look, they're great questions. I mean, how do you break down barriers between health and care? I mean, this is one of the eternal questions. It's not at all straightforward. I think, look, in the care sector, you have what? I mean, 15,000 odd providers, a third roughly are basically digitised, a third have a mixed economy of digital and paper, and a third are entirely undigitised. I think we can play collectively a big part in breaking down barriers by helping to get the third that's undigitised and the third that's only semi-digitised to a point where it's more digitised. They have basic infrastructure in place. We've been working with the telecoms companies to improve connectivity to the many care settings that don't have sufficient connectivity. Some brilliant work that Tara's been leading. And then I think it'll be a different approach to the one we take in the NHS, because obviously these are a lot of private, often charitable providers rather than sort of state. But I think a similar approach, in as much as setting out standards, building up good practice, sharing good practice, finding ways to bring the sector up in terms of its sort of digital maturity, and then having the mechanisms to share data across safely across care settings. And I mean, as I travel around the country, the bits of it that are really impressive are those places that have a shared care record or the equivalent that allows data to sensibly be shared between GPs and care homes and hospitals and trusts, so that care can be done in a much more joined up way. And when that happens, it's incredibly impressive. And when it doesn't happen, it's often, I mean, at really tragic cost. So look, there's a ton of stuff we can do there. None of it will be easy, but I'm confident that we've got an understanding of what needs to be done and an understanding of how important it is. In terms of some of the things we were ready to go on, I mean, look, some of them are the things we've announced that we're still really keen to do. We were desperately keen to start work, for example, on single sign-on and improving login times across the NHS, which continues to be a bugbear for any number of NHS staff. We were and remain really keen to take forward our programme of digital aspirants, so helping trusts across the system that aren't in that top quartile, who haven't been global digital exemplars or their fast followers, but nonetheless have aspirations to improve their own digital maturity and use digital technology to transform, to help them do that. We're still keen to do that, but I mean, improving digital infrastructure, going live on EPRs and things like that. I mean, this is the last few months has been a difficult time to try and do a big go live. So some of it, we're keen to take it forward, but some of it has paused. In terms of sharing success, I mean, definitely. The NHS is not good news or good practice and innovative practice doesn't sort of propagate across the NHS to the degree and at the speed we would like it to. We know that. I know it's something that you, Lisa and Tara, are keen to help with on the innovation front. It's also something I've asked our new CIO, Sonia Patel, who joined us a month or so ago from Northwick Park and Hillingdon Trusts, to focus on, which is how do we make sure that good practice and knowledge spreads more effectively? Because there is a ton of good practice out there, and people on the call know because they've created a vast amount of it. There are pockets of brilliant innovation, and one of the deep frustrations is that innovation doesn't spread the way it ought to, and we need to try and find ways to do that better, and part of that is sharing success.
Wonderful, thank you very much. Then just two more questions, and I thought I would open up the questions to all of our panel colleagues in the final few questions. So a question around the national screening programme and the NHS X involvement in that, and are we expecting that to recommence, the NHS X involvement in the national screening programme? And then a question on what can we say a bit more about Microsoft and the work that NHS X has been doing with Microsoft on behalf of the NHS as a whole.
So answer to the first one, yes, we are screening remains now an absolutely sort of key transformation programme for us. It's massively important and we'll be cracking on with it. In terms of the arrangement with Microsoft, this was really the resuscitation after about 10 years of an enterprise-wide agreement for the NHS with Microsoft. We had found ourselves in a position where we had every component part of the NHS negotiating separately a license arrangement with Microsoft vendors, and it just made sense to pool our buying power in a way that I think makes sure that we have a really good deal that we know has saved several £100 million for the NHS and ensures a consistent level of cover and cyber security for the system. So I think it's a really good step in all sorts of ways.
Wonderful, thank you very much, Matthew. That's been really helpful and given a great insight into what's been undertaken at a national level. And thank you for answering all of the questions. So we have a few final questions in the 10 minutes that we've got left, and some of them are quite broad. So I'm going to invite all of our colleagues. So I'm going to invite Matthew, Tara, James, Nina and Indra, if we can all mute all of those, our colleagues, so we can answer questions. So the first question is a very general question about supporting implementation and the importance of supporting implementation and how can we help. So I thought Tara might wish to answer that first, who's doing some work in that area. Then we'll hold it open to other colleagues who may wish to contribute also.
Sure, very happy to. And yes, we think that often the challenge with technology is not the technology itself, it's the implementation of it locally. I mentioned in my opening words that one of the things that we experimented with a bit during the COVID response was setting up a national deployment team that was predominantly volunteers from different organisations who just came together to help. We focused those teams on the digital primary care kind of part of the conundrum, partly on the basis that hospital trusts and mental health trusts do tend to have improvement teams that they were redirecting, but in primary care there really is nothing quite like that. We were really pleased with the results, and we got some fantastic feedback from the people that we were able to help. And one of the programs we did have to pause with COVID was a program we were about to embark on, working with regions to look at their scale and spread strategy. And we're just resuming that now. And at the moment, regions are developing their plans for scale, particularly around remote monitoring, both for COVID-19 at home, but also other long-term conditions. In looking after people at home or in a care home, because for over 400,000 people, that's what they're calling home. And we will, if those bids are compelling and convincing, we'll give support to regions to set up implementation teams. We recognise that bandwidth is really strapped across the NHS, and this would be a way of providing practical support. So that's our big focus for the second half of the year. It's part of the joining up care work that Matthew mentioned, but absolutely we want to work with other assets in the system and other people keen to help in this space to give practical support on the ground so that spread can accelerate more quickly than it has in the past. It does mean we've had to make some decisions because as a team we can't support everything, so remote monitoring is going to be our big focus for the second half of 2020 and into 2021.
Thanks very much, Tara. So we've just had a question come in around, there's been a lot of work on getting patient data to flow safely between systems. Can we say a bit more about getting staff data to flow? And Tara, I wondered if you wanted to take that one. I think this is the one about the digital passport, the staff passport.
Yeah, or Matthew, would you like to? You're really fond of the digital staff passport.
Yeah.
Do you want to say a word or two?
Yeah. Yes. I mean, it is it's a sort of keenly held aspiration. We've been working on a project which is actually led by the NHS England People Directorate. We've been supporting. We're not there yet, but. I mean, I think, again, one of the lessons of the last few months has been we need staff to be able to move quickly, and faffing around, spending days sort of comparing paperwork and doing unnecessary process at a point when the system is under extreme stress is not okay. So everyone, I think, sees the need for it. We just need to make sure the solution is the right one, and that's what we're doing at the moment.
Wonderful, thank you very much. And then I think the final question before we just come to a summing up is on procurements and the transparency of procurements and how we build the transparency of procurement and flexibility for procurement systems within the NHS. So quite a broad question on that. Who would like to answer that?
I'm happy to start, but others might want to jump in. So we have been, in normal everyday life, we probably wouldn't get into doing the things that we've done recently, but we are partway through 2 big procurement processes, and we've just used the normal standard procurement processes that exist, but to try and do that on behalf of the NHS to make it easier for them to draw down products. So the 2 that are currently live are on the clinical communications tools, which are tend to be app-based tools that help particularly doctors in training and other clinicians in their team communicate and share images and so on. And the second one is for remote monitoring platforms and portals. So they're the 2, and they've been, the first one was a accelerated OJU process. The second one uses an existing dynamic purchasing system called Spark. So they've been very open to the market. And even though we've been going at pace, we think it's really, really important to do that due to the commitment to the ecosystem.
Great.
Does anybody else want to add anything to that?
Thank you, Tara. So I think that's all the time we have for questions. I just wanted to finish up by making a final few comments. So this is the first session we've run in this way. Normally we meet you all face to face, so we've been disappointed we can't do that, but pleased to meet more of you over this forum. So the next session we're going to be running in early September, and we look forward to welcoming you onto that call. We've had a couple of questions around how people can get together and collaborate, so how our SME colleagues can get together and collaborate. So we'd like to have your ideas on that, and if people are happy to share their details, that's absolutely fine. We'll make sure those are circulated, and also if you're not happy to share details, that's fine too. But we would like some suggestions on how we can collaborate in the virtual space. So that would be really helpful, and please do continue to ask questions over the next half hour or so. So we'll be staying. The questions will be staying on the screen, and we'll make every effort to answer those, and we'll do a formal review and answer session for those tomorrow. I'd like to conclude by thanking all of our speakers. Thank you very much for all of your work during the COVID period, and all of your help to everybody out there in the system, and for sharing your work today. Thank you to our innovators for attending today. We're really pleased you could spend this time with us, and we'll be in touch on further events. There are a whole host of posts that are links to AI, links for our digital innovation site, so do get in contact with us if there are any specific suggestions, or you want to come and talk to us in more detail. Thank you very much, and I wish you a good evening.